Good afternoon, everyone. My name is Olivia Hensey from the New England QIN-QIO, and thank you for joining us for today's webinar, Session 4, Communication Tools, Part 1, Stop and Watch and SBAR Quality Improvement, PDA Cycle, with Sheila Eckenrode, Florence Johnson, and Carol Dietz. Before we get started, I'm going to quickly review a few housekeeping items. This call will be recorded for training purposes. I'll provide you with details on accessing the recording at the end of the webinar, and the phone lines will be on mute for the duration of the presentation. We'll take questions at the end, and I'll provide you instructions on how to unmute your lines. If you like, you can pose a question during the presentation in the chat box at the bottom right of your screen. Please make sure to send the question to all participants so that we can keep up with the incoming questions. We also will be having a couple polling questions, so just make sure that you are paying attention to the screen because those will be coming up. I'm going to now pass this over to Carol to get us going. Carol?
Good afternoon, everyone. Sorry I missed the webinar last month, but I'm here today. And before I turn the slide deck over to Florence, I just have a couple of things to remind people. Next slide, please. So, if you have signed the participation agreement with us, and there's 57 nursing homes that have signed the participation agreement with us, just a reminder that you have to participate in 7 out of the 9 webinars. This is our 4th webinar, so one of our new colleagues here at Qualidigm have been calling nursing homes, Julie Reed, just to let you know who is calling, has been calling nursing homes who have missed either 2 or all 3 of the previous webinars. So please know that we are tracking this, and this is part of the requirement in order to get an Interact participation certificate from us. Along with attending the webinars, you also have to send us at least 4 months of readmission data. Now, we would prefer you to put your data into Advancing Excellence and then sign a data use agreement with us here at Qualidigm, so then we can just do a data dump every month to look at the data to verify that you have been putting your data in. However, if you are with a corporate entity and you have your own readmission tool, you can go ahead and send us up to the minimum of 4 months worth of data, either by email or fax. So, and again, we'll be talking about this every month just to remind people, but this is really very important. The reason why we want you to send us your data is so you can start looking at your data and realize how important that data is, so you can track and trend all your readmissions and transfers to the ER. And finally, at the very end of the series, we're going to email each of your administrators and ask them to fill out the Interact checklist to verify all the different tools that have been implemented in your building. So this is a validation tool that we will ask your administrator to fill out. Next slide, please. Okay, so if you have missed any one of the webinars thus far, you can access them on our website, which is www.healthcarefornewengland.org. The link is right there on the screen. You click on events, you scroll down to previous events, and then you find the sessions that you have missed. There's going to be the slides, the recording, and the transcript all available on our website. Next slide, please. And these are the dates of our previous webinars. So, again, it's March 30th, April 27th, and May 25th, and obviously today. But you're on today, so it's good to go. Next slide, please. So these are today's objectives. Sheila's going to be talking about the Plan, Do, Act process so you have a better understanding about it. It's such an important quality improvement tool. Florence is going to be talking about the Stop and Watch as well as the SBAR tool. And then we're going to be we're going to have time this afternoon to go over the homework from last month and to talk about any challenges and barriers that you may have had. So without further ado, Florence, the floor is yours.
Thank you, Carol. So let me just explain something or talk about a little bit about what Carol talked about when it came to submitting data. If you have your own tool, please do not send us your patient protected information. We just want your numbers. If you're sending us your tool, we will not look at it, we will shred it. So just give us your numbers, not patient protected information.
Thank you.
All right. We have a polling question.
Okay. Jennifer, could you open up the line for the polling question, please?
So, every webinar we try to put in some polling questions to get people active in the discussion. So this polling question that we have is, since the last webinar, have you used the Interact medication reconciliation tool at least once? And maybe
that's not the right question. Stop and watch tool in your facility?
No.
Okay.
Okay. All right. We'll go ahead and use what's on the screen, which is how you're currently using the Stop and Watch tool in your facility. Technology happens. Do we still have time for that?
Yeah. Jennifer, are you able to reopen that polling question?
Sure, give me 1 second.
All right, we'll move on. Don't worry about it. So can you?
Okay, so the poll is open.
The poll is now open.
So are you currently using the Stop and Watch tool in your facility, yes or no? And don't forget to push submit so we can get your response.
This will take about 20 seconds. So please go ahead and submit your answer.
Doing that. Today's focus is going to be on communication tools, as we talked about, and these tools are tools that you're using within your facility to communicate with each other. And then the SBAR tool also goes out of your facility, but we're concentrating on how you are communicating with each other today.
Okay, poll has ended.
Sometimes if people don't press submit, we just
Right,
have to wait
yeah.
a little while for it to pop back up. There you go.
All right, well, 50-50. Hopefully, this will change after today. So next slide, please. We're starting today's focus with the Stop and Watch tool. And it's an early warning tool that's used to communicate between your non-clinical staff and your nursing staff. It communicates a changing condition, and it helps to start any discussion or evaluation of a changing condition. And this was developed mainly because the group that developed Interact recognized that nurses are very, very busy administering medication and talking to physicians, taking orders, talking with families during admission time. So we try not to interrupt nurses at this point to help keep the flow of what's going on the unit. So the CNAs initially were the ones that this tool was developed for. So they're very busy, and we try to make sure that direct staff has a way to communicate with nurses. And this is where Stop and Watch was developed from. Stop and Watch is effective. It's appropriate for everyone in your building who is not a clinician. Your maintenance people, your dietary, family members, anyone at all that lays eyes on your residents. So if you're planning on implementing Stop and Watch, which you should be after today, one of the first things you need to look at is your process. How are you going to order this tool? Who is going to be responsible for restocking it? Where are you going to keep it? How is it actually, just looking at how is it going to work from day to day. And then it's very important that you educate not only the CNAs or your non-clinical staff who are going to be using it, but it's important that you also educate the nurses, because they need to know what to expect from the CNAs and the non-clinical staff, and they also need to know what their role is in the implementation of Stop and Watch. Nurses have to understand that when a Stop and Watch tool is given to them, that's empowering the aide that has just given you that Stop and Watch tool to be able to communicate with you. So it's important that when you get that tool, that you own it and you thank them for that and you follow through with what was given to you. We want to make sure that the implementation is done slowly. So this is a copy of what the Stop and Watch looks like. So obviously it's an acronym, and I'm not going to read you all the details, but it should, the most effective way to use it is to make sure that it's NCR, so it's carbon copied. The nurse will get the white copy, and the aide will either keep a copy for themselves, the yellow copy, or they turn that into to administration. But when you do a rollout, it's important that you select one unit, you meet with the staff, you discuss the logistics of how you're going to do it. I would recommend that you make a copy of this and then put posters throughout your building to spark interest and to let them know that it's coming. It's not something you should start overnight. There should be some discussions, trial it for a week, meet with your staff to discuss how it's going to be used and any barriers that they see coming, because a lot of times when we're not on the front line, we don't understand what the barriers are that they're facing. So once you have done that, it's also important to talk about ways to improve the process. So you do this for about a week and you come back and you talk about how is it going to work. So the Stop and Watch tool is actually made so that it fits into someone's pocket. You really should not have an 8 by 10 size Stop and Watch. Next slide, please. Okay, we've already done the polling, so we'll go to the next one. As I talked about, the target audience is your CNA, but you want to make sure that your rehab staff, they spend a lot of time with your residents. Your dietary, housekeeping spends a lot of time in the rooms with the residents, especially in the morning, which a lot of times is when the change in condition happens. Your activity staff, laundry. Again, even the office people, because they see the residents come through and they might have a resident or two that's their favorite that comes in and talks to them. They may notice a change in condition before the unit people do. And then I talked about families and close friends. So they also spend a lot of time visiting in the room. Sometimes they take the resident out. Any opportunity that you have to put this Stop and Watch in the hands of your families would be great, because they take them out, things happen while they're out, and by the time they come back into the building, they've forgotten about it. But if they actually have something where they can document it and be able to share that with you, that is making them part of the team and making them feel connected. And if you're able to do that, then that's all part of your QAPI plan, because everyone in your building is involved in using this particular tool. Next slide, please. When should the Stop and Watch tool, when is it most effective? It's usually during personal care and during change of shift, when things are really, really crazy. This is a nice way to softly communicate anything that you see. And I've had nurses say to me, well, I don't want to get 20 Stop and Watch tools for the same change in condition. And my response is, I'd rather get 20 than not get any at all, because we want to make sure that we are focusing in on any subtle changes before it gets to the situation where it becomes an emergency and we have to transfer our residents out. Next slide, please. Some of the barriers that have come up that impedes the success of this is to have an inconsistent assignment. The whole point of Stop and Watch is that I know my resident. I know when something's not right with them before they're even able to either show symptoms or able to communicate the change. Staff turnover is a major barrier because when you have a lot of staff coming through, they don't get to know the residents. Broken relationships and communications between the CNA, between two CNAs or CNAs and the nurses. And what I say to people is our residents do not need to know what is going on with staff. So if there's any, and I'll use the words, there's any beef between staff, that needs to be left at the door. Our residents have worked their lives and they're here now to just relax and live the rest of their lives, and they don't need to hear the things that are going on between us. And then if we do that, we force them to have to take sides. Because when they're attached very close to one person and you are talking about that person, they own that and they don't deserve to be involved in that. Another barrier is resistance to changing verbal reports. And I talk to facilities all the time and say, well, we kind of start and then we stop because they still prefer to give verbal reports. That's the point of making a change. So once we implement this, no verbal report should be accepted by the nurse from any ancillary staff. If a person approaches with a verbal report, they need to stop them and say, I need to stop and watch. That keeps everybody accountable. Using it alone without any other part of interact, like the stop and watch and the quality improvement tool, the SBAR and the quality improvement tool, it's kind of pointless. And then lack of champion from the clinical side. If the nurses do not buy into this, it's going to be derailed, and you'll find yourself having to start over and over. All right, another polling question. Have you implemented the SBAR tool in your facility?
And Jennifer, if you could, perfect. Thank you so much.
So again, don't forget to hit submit so you can count. And we'll give you a few seconds. All right, while we're waiting for the polls to close, we will be talking about the SBAR tool, which is mainly for your clinical nurses, and it's actually a tool that helps you to frame how you're going to provide reports to your medical staff people. The poll has ended. So we should have results up in a second.
There you go.
Great. Oh, wow. Yay! All right, so those 4 that didn't answer, that said no, and the 14 that didn't answer, we will have you guys flip by the end of this Interact webinar. Next slide, please. The SBAR tool is a nursing communication tool. It communicates changing positions, and it's an effective way of bringing all the information together. It was initially developed by the military during wartime to give very quick report because they didn't have a whole lot of time to gather their thoughts. So, next slide, please. The purpose of the SBAR tool is to improve communication between the nurse and the provider. It's a way to have a consistent way of communicating. It standardizes the criteria, has clear guidelines, and again, it's an effective way to communicate. And this is all, a lot of times it's kicked off by a stop and watch being given to the nurse. Go ahead. I have some screenshots of the pages. It's not really meant for you to read it, but for you to see. It is a 4-page document, but it's mostly check boxes. The first page just gives you a checklist of things that you should have in front of you or have addressed before you contact a physician. The SBAR stands for situation. So why are you even calling the doctor or the APRN? The B stands for background. How has this happened before? What have you done? It looks at medications. It looks at vital signs. Page 2, please. And then on the second page is just a continuation, asking you questions about the different body parts. And this is where you can save yourself some time. If the change in condition is not relevant to some of the areas, you don't have to answer those questions. They even have the NA box that you can just check. So if it's a situation that has to do with GI, that's the area that you complete. Page 3 looks at the assessment, if it's an RN completing it, or appearance, if it's an LPN, and that's the A. And then the R is the request, and this is very important when you are talking about talking to the doctor. So if it's an on-call doctor who doesn't know your resident, this part brings it all together. This is what I see, and this is what I'm asking you for. So you're not giving the doctor's orders, you're just asking for what you think is appropriate for your resident, and you know your resident better than the on-call person. Thank you. Okay, sorry, thank you. So make sure that you empower yourself to be able to have good discussions with the doctor to say, this is what I'm looking for. And if they're giving you suggestions that you feel, send the person to the ER, but you have the skills to be able to take care of them in your building, make sure you advocate for that. At the end of the day, we are basically advocating for the people that we take care of. So to implement this, if you have not implemented it, is to make sure that, again, education is given as to why you are using this tool and the benefits of using it. And I'll give a quick example before I pass it over to Sheila. I was at a facility doing something else, and they were starting the SBAR Tool. Corporate had said everyone's going to start using this. The educator came in and just told the nurses, we're going to start doing this SBAR. And they were alarmed, saying, we already have a tool for documentation. Well, he was not able to communicate to them why they're using the SBAR and why it's important that we're switching over to this. He didn't even tell them that, okay, we're getting rid of the old system and using this. So again, if you're implementing it, education is important, and when you put this in place, you need to get rid of any other progress notes that you have, because it's duplication of effort. All right, and now I will turn it over to Sheila.
Thank you, Florence. Good afternoon, Interact partners. I want to talk to you a little bit about Plan, Do, Study, Act cycles. Some of you are probably familiar with this process, but if you're not, I want to give you a chance to think about this as you go forward implementing these tools. So the Plan, Do, Study, Act cycle is really scientific process. It's a way of solving problems. It's a paradigm for taking a hypothesis, making a guess as to what would work, and testing it to see if it does. Next slide. So I'm going to show you a little video and let Don Goldman, who's the Chief Medical Officer of the Institute for Healthcare Improvement, tell you about CBSAs in a way that's easy to understand and easy to share with your staff.
So for this video, we're probably going to need to go on the internet. Jennifer, is there a way for me to share my screen at the moment? Jennifer, are you on the line? You can have this video available.
Okay, we'll move on. Dr. Goldman explains this better than I do, but I'll do my best. So, say you want to implement stop and watch on a unit. So you're planning. Your hypothesis is we can implement stop and watch on one unit. And the thing about PDSA cycles that make them very effective is they kind of shrink down a big problem. So rather than saying, I'm going to implement Interact throughout my facility, you might think of implementing one tool on one unit, giving it a trial, seeing how it works. So there's the plan part. What are you going to do? Well, staff development might present the tool at the next staff meeting. You'll decide where to keep the pads with the actual tool on them, as Florence was saying. The charge nurse will begin at the end of every shift to ask CNAs if they have any stop and watch slips at the end of the shift, just to keep it fresh in people's minds, remind them that this is something we're doing. Maybe the shift supervisor will ask for stop and watch during her unit rounds, as well as care plan responding to change in resident condition. So that's the do part of it. Some other things you might do: bring stop and watch slips to the morning report. The shift supervisor can suggest a plan back to the nurse and the CNA. I don't know why I thought of where it always makes CNAs into cans, but we know who they are. And stop and watch slips will be shared with APRN and MDs that come to evaluate the resident, and whatever else you can think of. So you had a hypothesis. You said, I can do this. And then you made a plan of exactly what you're going to do. We've all done that, right? I said, I can lose some weight, and now I'm going to do it. And outline some steps. So how do you know if it's working? That's the most important piece of this. So the next piece that we're going to go through is studying it. So we all have these great ideas, and we throw them out there, but do they stick? So inherent in the PDSA process is the idea of measuring the effectiveness. And this can sound very grand, but it's very simple when you get down to it. So what might you look at? You might look at the number of stop and watch slips turned in. That's pretty easy to do. The number of stop and watch slips that resulted in a change in the resident care plan. You can get feedback from your staff, something as formal as a survey, or just walking around saying, what do you think of this new process? And then you can look at outcomes like unplanned readmissions or ED visits. The idea behind the study piece is that if it's not working, you need to start the cycle all over again with the pieces that don't work. So anytime we go to solve a problem using a PDSA paradigm, there's going to be pieces of that paradigm that seem to be working. There's going to be pieces of the plan that work, and there's going to be some that don't. So you want to tweak it. You want to go back and say, okay, well, you know, the idea of the supervisor collecting these, that didn't work. What can we do differently? Where can we put them so the supervisor can pick them up? Maybe they should go right to the morning report. So you're constantly tweaking the plan and making it better. And that is the last piece of that, which is the act. So you're asking, you know, what can we do to make this better? So it's working. Maybe we're going to roll it out to others, like the recreation staff or housekeeping. Maybe there's a suggestion that stop and watch slips may be made available to MDs and APRNs for routine rounds. Maybe CNAs say, I want to stop and watch that and keep it in my pocket. So you do this all the time. You do this in your life. We do this in healthcare. It's a way for us to systematically kind of have at a problem while continuously getting feedback as to whether our solutions really work. So when you get ready to apply a PDSA to a problem or to the implementation of a new process, like stop and watch or SBAR, the questions you need to ask yourself are, what are we trying to accomplish? What's the plan? What changes can we make that will result in improvement? That's the do. And how will we know that a change is an improvement? And that's the study. So I encourage you to use PDSA in implementing these tools and solving problems. And if you want to know more about this process and how best to use it, I encourage you to call any of us, and we will post that little video on our webpage. Thank you. And Carol.
Okay, thanks, Sheila. Excellent. We're coming up towards the end of our session, so now let's talk about our homework that we had from last month. So our session last month was talking about med reconciliation. And we had a wonderful speaker who actually has used the tool, recommends the tool, went through step-by-step on how a team should use the tool. So the homework that needed to get done this past month was before the next Interact team meeting, the team leader was going to download the MedRec tool from the Interact website and make copies of the tool for the team. So, as you have your meeting, you're going to start by reviewing the tool. And then also the team leader was to download the MedRec tool to one of your facility computers on a shared drive, and let everyone know where it's located. So if you run out of the tool itself, you can download more tools because it's free to download off the internet. The next piece of the homework that was the team was supposed to, during the meeting, you're supposed to review the actual tool. I went back to sorry. Discuss how and when the staff nurses, supervisors, and leadership and the medical director will be educated on the use of the tool. And then decide which unit's going to begin to use the MedRec tool with a new admission. And then you're also the team themselves is going to develop a timeline for implementation. And the plan was to include a debrief by the team and the participating staff as to how things went after the tool was used for the first time. Again, just like what Sheila was talking about, you want to start small. You don't throw out a tool and say, okay, everybody, here it is, and have at it. You want to have that plan in place. You're going to start small, one unit, one nurse, one new admission, and for this particular tool, and then see how it went. Next slide. So what we'd like to have, we're going to open up the line, and we would like some discussion about how things went this past month with the use of the MedRec tool. And how did it go, and how did it do, how was it talking to your medical director as well as your leadership about this tool? So Olivia, you're going to let everybody know how to open up the line.
Yes, so at this time we can take questions, comments, and to ask a question or to comment, please unmute your line by pressing #6, or you can pose a question in the chat box below, which we are moderating. Excuse me. Again, that's #6, or you can pose a question in the chat box. Make sure that you send it to all participants.
While you're thinking about how things went with the MedRec tool, we would also like to hear from you about how it's going with the readmission tracking tool, whether you're using Advancing Excellence or the Interact readmission tracking tool. By putting your data in, what barriers or challenges you may have come across, and what lessons learned can you share with others. So the two tools we're really interested in today is the MedRec tool as well as the readmission tracking tool. Come on, we know you're out there. There's 62 people out there. Oh, 61.
Again, it's
Can you hear me?
Yes, thank you.
Hi, we just had a comment. In using the Med Reconciliation tool, we do have our own tool here, and looking at both of them and trying to combine them into things that are the best use for us. But we are still struggling with the horrible Med Reconciliation coming from the hospital. And that seems to be our biggest barrier, because sometimes we can't even figure out where to start. It seems like the paperwork coming from the hospital is, the more they say they're fixing it, the worse it seems to be getting.
Have you sat down with either a case manager from the hospital or, it would have to be a case manager?
Yes, we're working on that process, but I just wanted to share that piece, that sometimes, talking to the family, they don't even understand what changed in the hospital. It's not thorough in the paperwork, and sometimes we're getting 3 different sets of discharge paperwork.
Oh, dear.
All different documents that they're using, and it's just getting more complex when they seem to be thinking that they're fixing it.
Are you able, can you tell us what facility you're in?
Sure, Bishop Wiki.
Okay.
Okay.
All right.
It's not a consistent, it just seems like, some of the patients that we have the most difficulty with.
Okay. Okay.
Hi, it's Sheila. Are these patients that are coming from EPIC facilities? Facilities that use the EPIC system, the EHR?
Yes.
Yeah, there's a problem inherent in that people, in their discharge planning process, docs and nurses and APRNs will continue to work on W-10, on discharge information over a period of time. So like if I'm in on Thursday, I might do my note on Thursday, even though the patient's discharged on Saturday. So there's problems there because, like you said, you're going to get conflicting information. It's hard
Right,
to
and sometimes it's just hard to go back and figure that out. You're right. I think that is one of the biggest problems with getting sources of information from too many people.
Yeah, and that the discharge summaries, like you said, it has contributions from so many different clinicians. However, that's a problem that they're acutely aware of, and I know the EPIC facilities that I touched upon, like Yale and Hartford, welcome the feedback, even though you said they know it, but just kind of being the squeaky wheel to shine a light on the magnitude of this problem. The other thing I couldn't help but think when you were speaking is, thank God you do medication reconciliation.
Yeah.
All that confusion, the probability of a terrible med error happening seems to be increasing.
So one of the recommendations I would make, if you can make copies of the reports that you're getting back, the discharge plans or discharge summaries that you're getting from the hospitals, obviously you may have to didact or get rid of the patient's name, but bring them back to the case manager to say, please share this with your IT team and also your throughput team within the hospital, because by showing them what they're sending out will help the problem, will help them realize that this is a true error waiting to happen. So if you could, and again, that's more work on your part, but yet in the long run, it's going to be better for everyone. So that's just one of the recommendations.
There are open lines of communication, and we do feel comfortable. We do feel comfortable doing that, and we have.
Excellent. Thank you. But thanks for shining that light on, because maybe some of the facilities don't realize that it's everywhere. So, and again, the more, as you say, there are open lines of communication, and you just got to let them know how hard it is sometimes when you receive these multiple plans, these multiple discharge plans. So thank you so much.
You're welcome. And I have one other quick question.
Sure.
Are these tools, such as the SBAR that we're using in other tools, are we to keep those as a part of the permanent medical record or use them as worksheets?
They should become part of the medical record.
So wherever you put your nurses' notes or progress notes for the nurses, that's where it should live.
Thank you.
And this is Sheila again. As Florence mentioned, the SBAR should be replacing your transfer note, your nurse's note, your change of condition note. The happiest thing is that you get 2 for 1, if you can replace 2 forms with 1 form, and makes everyone happier. But certainly don't add something without taking something away, or there will be mutiny among the staff. They have enough paperwork.
So thank you for the question. Okay. Anybody else have some lessons learned? Anything you would like to share with your colleagues?
Is anyone using the tracking tool that would like to talk about it?
Hi, Florence.
Yes.
Hi, Florence. Yes. This is Brenda Merriman from Chestham speaking. We've been using the medication reconciliation tool. We haven't really found any significant differences, although we have found by reading the discharge summary there's other discrepancies in the body of the discharge summary itself. and not with the list of medications. So, you know, I guess I would just make sure that reading that thoroughly, you can pick up on other things as well.
That's a good point. Very good point.
Thank you. Thank you very much.
You're welcome. You're welcome.
That's a great lesson learned. Thank you for sharing.
All right, is Talbot Health on the line? John, are you on the line? Can you unmute yourself? I told you I was going to pick on you.
Pound 6.
So unmute your line. It's pound 6.
Hi, this is John.
Hi, John. How are you?
Good. We started using our internet tracking tool for admissions. We just got a new DNS here, and she was very familiar with the program. So we rolled it all together here, and we started. We were supposed to start July 1st, but we started actually today. We had our first new admission, and we're tracking them. So we're hopeful.
That's great. Now, what were you using before the tracking tool?
We had like a homegrown system that was written down on calendars and things, and I'm glad we're going to this. This is very nice.
Awesome. Well, keep in mind that we're here to provide you support if you should run into any hiccups at all, but it sounds like your DNS has it going on, so you're all set.
All right, great. Thank you very much, everyone.
For speaking up.
Okay, any other lessons learned that you would like to share with your colleagues?
Sheila, this is Jean from Bradford. Thanks for helping me this morning.
Shout out, Jean.
I'm glad that you clarified that when you do your readmission rate, you do the whole facility, not just your subacute. So we went from 4% readmission to 3%.
Woohoo! How easy was that? Well, I'm sorry, I'm glad you mentioned that because honestly, it's a true statement. I've had quite a few facilities say to me, why aren't my numbers coming up? And when we talk about it, it's that they're only looking at their post-acute care. You have to put in the whole entire facility. So thanks for bringing that up.
Thank you. You made my day there. I have a question, though. If someone goes to the ER, dies in the ER, does that count as a readmission? Or if somebody goes to the ER, gets admitted, dies in the ICU, what's the difference?
If they're readmitted, if they actually get into a bed and pass away, if it's within that 30-day window. So you have your tracking tool, and anyone who's admitted into your building is highlighted in yellow, which means if they're at risk for a 30-day readmission. So if they go out within that 30 days and they don't come back for another 3 days and they're actually admitted, their name will now turn red, meaning that they suffered a 30-day readmission.
Okay, but if they die in the ER?
Then it's an ED visit.
Yeah, then it's an ED visit.
You know, that would be a good case to do a root cause analysis on or a review, because that's the last thing we want to do is send someone somewhere to die.
Right.
This should be a very rare occurrence. Sort of an unexpected death. So,
You know, unfortunately, we're finding, and we're going to be doing a QI on that, is that a lot of the residents we get, their hospital discharge says they should be on hospice care. But then when they get here, the family denies hospice and wants them to be treated as normal, and those are our frequent flyers.
Yeah. And that might be a discussion to have with your acute care providers, because if they're recommending hospice, that should really start in the hospital. They should not send them home to start having that conversation again. So if they're feeling this person needs hospice, hospice can go in and do an evaluation while they're still in that acute care bed.
Some of the hospitals do have a palliative team, you know, and we're thinking about starting a palliative team here. So even if they come back here, perhaps we could cajole the residents into, not the residents, their families, you know, like, you want this, you want them to die in comfort, or you want them to die in a medical atmosphere.
And as a matter of fact, in a few months, we'll be going over the advanced care module that's part of Interact. So hopefully those tools can help you, get your palliative care up and running and get the staff much more comfortable talking about it at admission as the patient's entering the facility instead of after an admission or readmission back from the hospital.
Yeah. All right. Well, thank you very much.
Excellent question. Thank you.
Anyone else have any questions before I start picking names again? I have somebody in mind if somebody doesn't speak up. Doug, what are you guys doing over there at Park Place? Can you unmute yourself?
That would be pound 6 to unmute.
Okay, he signed on and is not listening. How about Lucia? What are you guys doing over there at Touch Point? Pound 6.
This is Lucia from Touch Point of Farmington.
Excellent.
This is Lucia from Touch Point of Farmington. Yes, we are using the transfer log to track our transfers out to the hospital, and we did find a way to enter the data more accurately now. We're using a morning report to identify, we call them the pinks, greens, and yellows. So we know those who are at risk, and it's very helpful for the entire team.
Wow, you're doing it the way it should be done. Excellent. Thank you for volunteering to speak up.
As you're getting pulled off of the phone.
Anybody else want to volunteer to speak? How about you, Bernadette? You've been doing this for a while. Like to speak up, pound 6?
Hi, Bernadette had to step out to another meeting. This is Dave. I'm going to be covering for her when she's out.
Okay, what do you want to share with us, Dave?
I was just listening in towards the end here to try to get an idea of what the different tools are, and I know we're definitely working on the discharge tracking tool and the readmission tool, because that's what I've been oriented to so far. It's only my 3rd day here, so. I got this part.
Good job.
I'm going to let Bernadette know that you rocked it. You actually were able to unmute yourself and talk.
No problem.
Thank you.
All right, thanks.
Thank you. Okay. Good job, you guys. Again, this time is really a good sharing time to listen to how others are using the tools, what's worked, what didn't work, and again, to ask those questions that you've just been burning for the past month. So thank you all for the great discussion. If we can go on to the next slide, let's talk about homework for the next month. So, okay, prior to your next Interact team meeting, and hopefully each of the buildings that are on, you do have an Interact team, which could be your QAPI team, and that's fine, but you got to make sure that you're going to work on this Interact Quality Improvement Program for the next 6 months, because it really takes a good year to really implement the tools correctly, to do those PDSA cycles, to make sure that they're in place properly and everyone understands the tools and why you're using them. So prior to your next meeting, the team leader is going to go onto the Interact website and download the 2 tools that Florence talked about today, Stop and Watch and the SBAR Tool. And you're going to make copies for the team. And then also the team leader is going to download both of these tools to a facility computer on a shared drive so other people can have access to them. Because what we have found back in the last year when we were doing this series of webinars, the team leader would have access only to these tools. They would leave or go on vacation, and nobody knew where they were, and so that was one of the major barriers we saw. So you want to make sure once you download them to a shared drive, you let the entire team know where they're located, and you actually practice going in and downloading them and printing them off. Next slide, please.
Can I just, that's what Carol was saying, this is culture change at its core. We want this to be something that you're living every day, and we will say this every month. It's not about checking a box. It's not about saying, all right, well, we'll start it so we can get our certificate. Don't forget, your residents aren't going anywhere. They still live there. So it's about living and breathing Interact because it's the right thing to do.
Thanks, Florence. That's perfect. All right, during your next team meeting, you're going to review both of the tools, discuss how and when the staff nurses, supervisors, the medical director, and APRNs will be educated on the use of the SBAR tool. Remember, this is the clinical tool on how you're going to communicate internally with each other as well as this tool, and we will be discussing this in a couple of months on how this tool gets actually copied and sent out to the hospital for an acute care transfer. So you want to be using this tool correctly from the get-go. And once you start the education of the staff really should practice using the tool during this education. They can practice with each other, they can practice with the supervisor before you actually start using the SBAR tool. Then then the team's going to decide which unit's going to start using the tool with one patient. The next patient that's going to be transferred out is going to be the SBAR tool is going to be used, or the next change of condition, I should say, not transfer out. The next change of condition of a patient, the SBAR tool should be used. And also going to talk about where the tool is going to be located so the nurses have easy access to it. And also you're going to make sure you change your policy to say that the SBAR is now going to be part of the resident's chart. And then you're going to develop a timeline for implementation. Next slide, please. And so finally, during the team meeting, you're also going to be talking about educating the entire staff on the use of the Stop and Watch tool. This is a great tool, and as Florence says, it really empowers the family. It empowers the non-clinical staff who feel, they love your residents. They clean their rooms. They bring them their dinner. They know the residents so well, and they want to be part of the team that is caring for them. So this tool is phenomenal. Again, you're going to decide which unit will begin to use this tool. You're going to use it on one unit, do a PDSA cycle, review how it goes, and then you start spreading once you get it down to a point where it starts to work really well. And then you're going to implement a timeline for implementation. And remember, whenever you use a new tool, the first time it's used, you should include a debrief after it's been used by the team and the participating staff to see how things go or how things went after the tool is used for the first time. So, always during your team meeting, you're going to talk about your tracking tool. How's it going? Is it being updated daily? Are there any barriers? And so you got to talk to the team member that's putting the data into the tracking tool, because at the end of the month you will get the previous month's readmission data. So whenever your team meets, you always look at your readmission tracking tool and the data that it's producing. So with that being said, are there any questions, any other comments, any concerns that anyone would like to share with the team? Again, #6 if you would like to have a comment. We just got a question from comment from the chat box. It's about the point of care. Point click care. Has a Stop and Watch tool in the program. This makes it always available to the CNAs. Also, we made the SBAR in our EHR, so nurses have immediate access. Excellent. That is outstanding. That is using your technology appropriately, and everybody has access. So thank you, Brenda, for bringing that forward.
The only thing I would add to that is that if you do have the Stop and Watch built into your EHR, you've got to make provisions for how that information is going to be carried on to the 24-hour report system so that you're addressing it, and also making sure you're closing the loop by going back to the aide to say, okay, you reported this, this is how we handle this. That part of it is very important. I forgot to mention that before. So whoever's making the notification should be given a report back on how that situation was handled. And always remember that Sheila, Carol, and myself are here to support you, and that you should not suffer silently. If you're having any kind of pain related to rollout, please let us know, and we can provide you with technical assistance.
Okay, so we're going to close it down for today, but thank you all so much for your comments, and Olivia has a few housekeeping items before we leave.
Thank you, Carol, and thanks everybody for a great discussion. I just have a few last-minute announcements before we end today's call. When you close out of this webinar, the evaluation will automatically pop up on your computer. If you could please fill that out, you would greatly appreciate it. If you don't have time to fill out the evaluation right now, or you're currently sharing a computer with someone else, you'll receive an email tomorrow morning with the link to the evaluation, as well as the link to the event page on our website. The PowerPoint presentation is posted on our website, and within the next few business days, a recording and a transcript will also be added. The email tomorrow morning will also include a link to the video that we were unable to show today that Sheila was presenting on. Be on the lookout for emails about our next webinar, and thank you again for attending, and have a great day. Thanks.
Bye, everyone. Thank you.
Welcome.
Hello?
Hi. Here.
Hi, Silver Springs wasn't able to attend roll call, but we're on the call.
Okay. Thank you very much.
Thank you.
All right. Have a great day. Thank you. Happy 4th of July, everyone. Bye-bye.